So, good morning to the respected teachers and the seniors. So today I am presenting the background study of the perioperative nivolumab versus the observation in patient with the renal cell carcinoma undergoing the nephrectomy. So the worldwide incidence of the renal cell carcinoma estimated around the 4 lakh of the new cases annually, and the worldwide mortality rate approximately the 1.75 lakh deaths per year. According to the Globocon 2020 data, the kidney cancer constitute around the 1.3% of the India's total cancer cases, and the incidence stands at the 2 to the 1 lakh in case of the males and 2 or the 1 per the 1 lakh of the females. As per data from the TMS Mumbai Kata in India, the median age at the presentation of the renal cell carcinoma is the 56.6 years. 56.6 years. So till date, Kata only the adjuvant data was available in case of the renal cell carcinoma patients. So the first time discussing the adjuvant sunitinib or the sorafenib for the high risk of the non-metastatic renal cell carcinoma. It is a double-blind, placebo-controlled and the randomized phase 3 trial. This study was done at the 226 the study center in the USA and Canada between the April 24th of the 2006 to the September 1st of 2010. And the total number of the patients were 1943 were included. The inclusion criteria of this study includes the histologically proven, completely resected, high risk renal cell carcinoma or the non-clear renal cell carcinoma within the 12 week of the removal of the primary tumor. And the other is the high risk include the pathological T1B or the grade 3 to 4 N0 M0 and the ejection fraction 50% within the 4 week before the randomization, ECOG-PS 0 to 1 with the normal liver and the hematological function, and create clearance is more than the 30 ml per minute. Exclusion criteria of this study includes the uncontrolled hypertension, pre-existing thyroid disorder, known case of the HIV infection, patient with the medullary kidney cancer and the collecting the kidney cancers. Initially, the patients were randomly assigned to the 1:1:1 ratio. So first group received the sunitinib 50 milligram per day orally throughout the first 4 week of the each 6 week of the cycle, and the sorafenib 400 milligram twice a day orally throughout the each cycle. And the placebo could receive the sunitinib placebo group given the continuously of the 4 week of the every 6 week cycle, or the sorafenib placebo given the twice per day throughout the study. The primary objective was to compare the disease-free survival between the each experimental group and the placebo. So the study concluded that the median disease-free survival was 5.8 years for the sunitinib with a hazard ratio 1.02 and the 6.1 years for the sorafenib group with a hazard ratio 0.97 and the 6.6 years for the placebo group. And in case of another study, the adjuvant sunitinib in high-risk renal cell carcinoma after the nephrectomy. This is a randomized double-blind phase 3 trial, which includes the 615 patients, and the study started from the 19th September 2007 to the 7th April 2011. The eligibility criteria of this study includes the age more than 18 or the equal to the 18 years, locoregional renal cell carcinoma, tumor stage 3 or the higher, original lymph node metastasis or both. Histologically confirmed case of the clear cell renal cell carcinoma, no any previous systemic treatment received, or the ECOG not more than 2, and treatment initiation starts within the 3 to 12 weeks after the nephrectomy, and absence of the macroscopic residual or the metastatic disease after the nephrectomy. Exclusion criteria includes the renal metastasis, histologically undifferentiated tumor, diagnosis of second cancer within the 5 years before the randomization, and major cardiovascular events or the disease within the 6 months before the enrollment, and uncontrolled hypertension at the time blood pressure is more than 150 by 100 millimeter of the mercury. In this study, the patient were assigned into the 1:1 ratio and receive either the oral sunitinib 50 milligram per day or the placebo on a 4 week or the 2 week off schedule for the 1 year or until the disease recurrence, unacceptable toxicity or the consent withdrawal. So this study concluded that the median duration of the disease-free survival was 6.8 years in the sunitinib group and the 5.6 years in the placebo group with hazard ratio 0.76. Another study of the adjuvant pembrolizumab after the nephrectomy in the renal cell carcinoma. This is a double-blind phase 3 trial. Total 994 patients were randomly assigned to receive either the adjuvant pembrolizumab or the placebo. In pembrolizumab group, the number of the patients were 496 and in placebo 498 patients were included. The pembrolizumab, in this study, the pembrolizumab dose of the 200 milligram or the placebo carrier the saline were administered intravenously once every 3 weeks for a maximum of the 17 cycle, approximately 1 year, or until the disease recurrence, unacceptable toxic effect, or the intercurrent illness. The primary endpoint of this study was the disease-free survival. This study concluded that the pembrolizumab therapy was associated with significantly longer disease-free survival than the placebo. The disease-free survival at 24 months, 77.3% versus the 68.1% with a hazard ratio for the recurrence of the death is 0.68. Grade 3 or the higher level of the events of any causes occurred in 32.4% of in pembrolizumab group and 17.4% those who received the placebo. Another study of the adjuvant atezolizumab versus the placebo for patients with the renal cell carcinoma at increased risk of the recurrence following the resection. IM Motion 10 trial. In IM Motion 10 trial is a randomized, double-blind, multi-center phase 3 trial conducted in 215 centers in 28 countries. Total 778 patients were enrolled and 390 were assigned to the atezolizumab group and the 388 to the placebo group. So after nephrectomy with or without the metastectomy, the patients were randomly assigned 1:1 to receive the atezolizumab 1200 milligram or the placebo, both the intravenous, once every 3 weeks for the total of the 16 cycle or up to the 1 year. This study concluded that the median investigator assessed disease-free survival was 57.2 months with the atezolizumab and 49.5 months with the placebo group with hazard ratio 0.93. The most common grade 3 or grade 4 adverse events were the hypertension in case of the 2% of the patient, those who receive the atezolizumab, or the 4% in those who receive the placebo, and hyperglycemia, and another one is the diarrhea. So this one is the brief chart of the till now what are the study done into the keynote 564 related to the pembrolizumab, where the disease-free survival at the 24 months were the 77.3% or the 68.1%. In case of the IM Motion trial of the atezolizumab, the disease-free survival was 57.2 months with confidence 95% confidence interval and the 49.5 months with a placebo group. And this data also showing the adjuvant of the TKI, in which the SEO trial showing the sunitinib group or the sorafenib, in which the sunitinib, the 50 milligram receiving the 50 milligram per day with the initial 4 week and the of the last 2 week, and the sorafenib received the 400 milligram twice a day. And the primary outcome in case of sunitinib group with the disease-free survival is the 5.8 years. And another one is the S-track trial of the sunitinib, in which the patient received the 50 milligram of the sunitinib continuously for a week and the 2 week off, or the another one is the placebo group. And the primary outcome of this study is the sunitinib group, the median disease-free survival is the 6.8 years, and the placebo group is the 5.6 years.
Thank you, Dr. Ravindra. I think Dr. Randhir is next. Can you share your screen?
Yes, sir.
Yeah, I think Dr. Ravindra, you have to stop sharing.
Coming to methods and results part of the study. It is study design. It is an open label randomized phase 3 trial conducted across 183 sites in USA and Canada, targeting patients with untreated renal cell carcinoma. The eligibility included patients aged 18 years or older with ECOG performance status 0 to 1, clinical stage T2 or higher, any T with node positive RCC, who are planned for nephrectomy with no evidence of metastatic disease. At latest part of study, the patients with select oligometastatic disease up to 3 metastases were allowed, and if treated, to have no evidence of disease within 12 weeks post nephrectomy, excluding brain, bone, liver metastasis. And the patients with history of partial nephrectomy, known autoimmune disease, active liver disease, HIV, significant autoimmune condition, are those requiring ongoing systemic corticosteroids or immunosuppressive agents, and patients with other malignancies requiring active therapy within past 3 years are excluded. And the patients required adequate organ function with creatinine clearance of 40 ml per minute or greater and non-active hepatitis B C serology. The patients provided written informed consent, and the study was approved by central and local institutional review boards with input from patient advocates of different organizations to ensure patient-centric trial design. The patients coming to the randomization and masking, the patients were randomly assigned in a 1:1 ratio to either nivolumab plus surgery or surgery alone. And the randomization method included a permitted block design. Block sizes of 4 was used within each stratum to ensure balanced assignment. The randomization was stratified by clinical T stage, TX, T1 or T2 versus T3 or T4. Clinical node positivity, N0 versus node positive, and clinical M stage, M0 versus MX. The treatment assignments were obtained through ECOG-ACRIN Cancer Research Group's web-based randomization system, accessed via the National Cancer Institute open interface by enrolling sites. And the patients, investigators, and study staff were not masked to the treatment assignments, whereas the assessors and the data safety and monitoring committee were masked to treatment group assignments to ensure unbiased evaluation. And the masking of assessors in the DSMC was done to maintain objectivity and avoid bias in assessing study outcomes. Procedures. Initially, all the patients were required to undergo a corneal biopsy of the primary tumor before randomization, but later this requirement was amended to apply only to those in the investigational group, and those with inconclusive biopsies were included in intention to treat analysis. And the nivolumab dosing regimen, which was used in this investigational group, initially dosed at 240 milligrams every 2 weekly for 2 doses before surgery, and continued post-surgery every 2 weeks for 9 months. But after the FDA approval of nivolumab, the regimen was changed to 480 milligram every 4 weekly with 1 dose before surgery and 9 adjuvant doses post-surgery. Whereas the control group underwent nephrectomy followed by standard of care surveillance with no placebo administered. And the dose omissions, not reductions, were permitted for grade 2 or worse adverse events, and the permanent discontinuation was required for severe immune-related toxicities, which include grade 2 pneumonitis, grade 3 renal or cardiac events, or other worse adverse events which last more than 7 days. And the patients were followed for adverse events for 100 days after the last treatment or surgery. And then for low-grade adverse events, the nivolumab was resumed within 12 weeks after resolution of low-grade adverse events. And the patients had baseline scanning done, and the regular imaging was done every 4 months during the treatment, then every 6 months for 2 years, and annually until year 10. The recurrence was assessed based on imaging and, when possible, biopsy confirmation. Data on sex, race, ethnicity were collected via self-report on a case report forms, and the adverse events or deaths were attributed to study treatment by the study site. From the March 2020 onwards, due to COVID-19 pandemic, virtual or in-person follow-up visits were allowed. Coming to the outcomes of the study, the primary endpoint was investigator-reviewed recurrence-free survival for patients with RCC of all histologies, defined as the time from randomization to disease recurrence or death from any cause. Now, this recurrence-free survival was compared within the two groups, one receiving the perioperative nivolumab along with radical or partial nephrectomy, and those who underwent surgery only. Secondary endpoints included a recurrence-free survival, especially in patients with clear cell RCC, and overall survival for all the patients regardless of histology, and safety and tolerability of perioperative nivolumab. The data collection is ongoing for correlative outcomes, which included PD-L1 status, patient-reported outcomes, and quality of life assessments using different scales. And there is also ongoing exploratory analysis of radiographic images and biological specimens with results to be reported separately. Coming to the statistical analysis, the study aimed to enroll 805 patients to achieve a target of 766 patients with RCC, accounting for potential inclusion of patients with benign or non-RCC lesions. And the approval was planned at 264 patients per year over a period of 2.9 years with 2.6 years of additional follow-up. The primary study was designed with approximately 84.2% power to detect an 11.7% absolute benefit in recurrence-free survival for nivolumab plus surgery when compared to surgery alone, with hazard ratio of 0.7. And the efficacy interim analysis was planned at 65%, 85%, and 100% of the full information for RFS events using O'Brien-Fleming error spending. And the inefficacy interim analysis was started when 44% information was available, and it recurred semi-annually if sufficient new data was accumulated. The primary RFS analysis was performed on all randomly assigned patients confirmed to have RCC. Patients not receiving surgery or not disease-free post-surgery were counted as having events on day 1 itself. And the patients receiving non-protocol therapy before disease recurrence were censored at date of non-protocol therapy. Its sensitivity analysis censors such patients at day 1 instead of counting as events. The study used a hierarchical testing approach where secondary endpoints were assessed only if the primary endpoint was significant. Since primary endpoint was not significant, the secondary endpoints were analyzed as a part of secondary analysis. And the secondary analysis included recurrence-free survival in clear cell RCC patients and overall survival for all patients. And the OS analysis was performed post hoc with focus on a 5-year OS. And the pre-planned subgroup analysis also was done based on histology, sex, race. The post-hoc analysis included further subgroups based on clinical and pathological TNM stage, Foreman grade, age, ethnicity, histological subtypes. And this post-hoc analysis compared the trial data with those from Keynote 564 and Checkmate 914 studies, and the landmark analysis of recurrence-free survival at 10 months based on nivolumab dose was conducted. And the post-hoc analysis also examined the time from the enrollment to surgery and the time to adverse events and treatment discontinuation. Statistical methods, stratified Cox proportional hazard models were used to estimate hazard ratios for RFS, and the time to event endpoints were characterized using Kaplan-Meier method. Categorical variables were compared with Fisher exact test and continuous variables with Wilcoxon rank sum test. A p-value of less than 0.05 was considered significant, and all the analysis was conducted using R software version 4.0.5. This is the trial profile of the study, where 819 patients were randomly assigned to treatment. Out of those, 404 assigned to nivolumab plus surgery group, out of which 381 are with RCC, which is the primary analysis population. Out of these 381, 366 received at least one dose of nivolumab or received surgery. 38 did not receive nivolumab and did not receive surgery. 45 did not receive surgery on the study, when compared to the control group, where 415 was assigned to surgery alone, and the primary analysis population is 399. Out of the 399, 387 received surgery, 28 did not receive surgery. And this is the demographic and clinical characteristics of recurrence-free survival analysis population, which I will be explaining later. Coming to enrollment and randomization, between February 2017 and 2021 June, 819 patients were enrolled and assigned randomly to two groups: 404 patients in nivolumab plus surgery group and 415 patients in surgery alone group. Out of this, 91% of patients in nivolumab plus surgery group and 93% in surgery only group started their assigned treatment. However, 11% of the patients in nivolumab group and the 7% in surgery only group did not undergo surgery. And in the nivolumab plus surgery group, 356 patients received nivolumab, but 22% did not complete protocol-specified adjuvant therapy, 16% discontinuing because of adverse events. Only 53% of the patients completed full course of nivolumab. The patient demographics in the study were predominantly male, with 70% with median age of 61 years. And the majority of them are white and 10% were Hispanic or Latino. And at enrollment, 14% of the patients are clinical stage 2 disease, 15% were node positive, and 3% were resected oligometastatic disease. Both the treatment groups were well balanced at baseline concerning age, sex, race, ECOG performance status, clinical TNM stage. And the recurrence-free survival was at the final analysis, the hazard ratio between the two groups was 0.94 with p-value of 0.32. Which indicating no significant difference between the groups. The subgroup analysis showed no significant difference in recurrence-free survival even when considering only patients with clear cell RCC. The hazard ratio for this group was 0.91. And the overall survival of post-hoc 5-year OS was 73% in nivolumab plus surgery group when compared to 81.1% in surgery only group, with a hazard ratio of 1.28 with p-value of 0.26. And 96% in patients in the nivolumab plus surgery group experienced at least one adverse event of any grade, which compared to 78% in surgery only group. And the grade 3 to 5 adverse events occurred in 48% in the nivolumab group and only 24% in surgery group. 22% of the patients who received nivolumab discontinued therapy because of adverse events. 5% died due to RCC or other causes. Whereas in the surgery only group, 6% died due to RCC or other causes. And deaths due to treatment-related adverse events occurred in 2% of the patients in nivolumab plus surgery group and less than 1% in surgery only group. And the study and the nivolumab dosing, the study maintained a consistent full dose of 480 milligram nivolumab throughout although the dosing schedule was modified in between. And the post-hoc analysis, landmark analysis was done at 10 months, showed no significant difference in RFS between patients receiving more than 75% versus 75% or less of total nivolumab dose. And after eliminating the mandatory core biopsy requirement in surgery group, the median time from the enrollment to surgery decreased from 32 days to 21 days in nivolumab plus surgery group. And the time to surgery and adjuvant therapy, the median time from the last preoperative nivolumab dose to surgery was 14 days. And the median time from surgery to start of adjuvant nivolumab therapy was 38 days. 37% of the patients discontinued nivolumab therapy within the first 6 cycles, with 59% of those who stopped because of adverse events, permanently discontinuing without grade 3 or worse treatment-related adverse events. And the post-hoc subgroup analysis, including comparisons with other trials, Keynote 564 and Checkmate 914, showed results consistent with primary RFS outcomes. And the impact of nivolumab on the surgery timing showed that the introduction of nivolumab in neoadjuvant nivolumab did not significantly delay the surgery compared to the surgery-only group. In the final, the study found no significant benefit of adding nivolumab to surgery in terms of RFS or OS, and the trial was stopped early due to futility based on interim efficacy results. And this is the recurrence-free survival showing there is no significant difference between the two groups with a hazard ratio of 0.94 and p-value of 0.32. And this is the forest plot of recurrence-free survival according to different subgroup analysis, which is now showing across the various subgroups, there is no significant difference between the two groups.
Randhir, I think you can stop screen sharing. Arvind, you can share your screen.
Can I share my?
Yeah, screen sharing is ended.
Just switch off my audio and sometimes. Switch off your audio and sound. Sir, am I audible and visible to everyone?
Yes, yes, you can start. Yeah, just make it full screen and you can start.
So is it okay? Yeah. So, with this trial, it was not proven that perioperative nivolumab improves recurrence-free survival in patients with resectable RCC. But in order to eliminate potential confounders, what they did is first they censored the patients who did not receive surgery and who were not disease-free after surgery, thinking that inclusion of these patients might be confounding the results. But even after removing these patients, there was no difference in the recurrence-free survival. Secondly, they also realized that a lot of patients could not complete the full course of nivolumab, and hence they decided to do an analysis of two groups of patients: those who received 75% or more doses, and those who received less than 75% doses. So even the patients who received more than 75% doses did not have an improvement in the recurrence-free survival. So the assumption that failure to complete the full adjuvant nivolumab led to a suboptimal result was not true. So the lack of improvement in survival was not due to inadequate nivolumab dose. And in terms of safety and feasibility, we saw that there were grade 3 to 4 adverse events, which was similar to that of other adjuvant immunotherapy trials. So we know that surgery has always been the gold standard for non-metastatic RCC, but the issue is it is having very high recurrence rates. In intermediate and high risk patients, we have 39% and 58% 5-year recurrence respectively. Hence, there is a need to develop some sort of adjuvant treatment in this group. So I will give a brief review of adjuvant TKI. So initially the trials were on TKI. So adjuvant sunitinib in the STRAC trial, in which they divided patients after surgery to adjuvant sunitinib or placebo for 1 year. And there was a non-significant improvement in DFS. But based on this trial, there was an FDA approval for adjuvant sunitinib. However, the other trials did not show any benefit. In the ASSURE trial, they tried sunitinib or sorafenib versus placebo. And they had 3 groups: sunitinib, sorafenib, and placebo. Result being no difference in DFS and significant grade 3 and grade 4 adverse events. In the EVEREST trial, they have compared everolimus versus placebo in the adjuvant setting in the intermediate high and very high risk group. And this showed there was a small benefit in the very high risk group, which was just about significant, with no difference in OS and significant grade 3 to 4 adverse effects, especially mucositis, hypertriglyceridemia and hyperglycemia with everolimus. This is also not recommended. In the ATLAS trial, they have tried another TKI, axitinib, in the adjuvant setting, in which again they included these intermediate and high risk patients of axitinib versus placebo, and the result shows no significant difference in DFS even in the high risk population, and once more significant side effects like hypertension and dysphonia. Axitinib is also not recommended. And the last TKI that was studied in the adjuvant setting in RCC was pazopanib in the ECOG-ACRIN-E2810 study. And they received pazopanib 800 mg per day versus placebo for 1 year. And again, we saw that there is no difference in DFS or OS. In fact, the OS was better in the placebo group and very poor quality of life in the patients who received pazopanib. So hence, pazopanib is also not recommended. So this is just a summary of all the trials, the 5 TKIs that were tried, and there is no improvement in survival except for one, that is the STRAC trial, which led to FDA approval of sunitinib in the adjuvant setting. However, in Europe, the EMA still did not approve. So only the US FDA approved this drug. And because of the conflicting results between STRAC and ASSURE, this was not able to be adopted as a standard recommendation, coupled with the severe side effects of TKIs. So since TKI did not show benefit, there was a trend key, let us try adjuvant immunotherapy. Because in metastatic RCC, there is an excellent survival benefit with immunotherapy. So in terms of IO, the first trial that was done was the Keynote 564, in which they gave adjuvant pembrolizumab after nephrectomy, which included clear cell or sarcomatoid high-risk patients. They received adjuvant pembro for 1 year or placebo for 1 year. And this showed that the OS in the pembro arm was 91% versus 86% in the placebo arm, which was significant. The DFS was also prolonged, and there were expected 30 to 35% side effects of grade 3 or more in the pembrolizumab arm. This pembrolizumab is approved and it is included in the NCCN as a category 1 recommendation in adjuvant treatment of clear cell RCC. And we saw that in this keynote trial, the curves are separating early. The green one is for pembro and the red one is for the placebo. The second trial was the Emotion 10 trial, in which they studied adjuvant atezolizumab. So in this trial, they randomly assigned patients for atezolizumab or placebo for 1 year, again including the intermediate and high risk patients. But in this trial, they saw that there was no improvement in DFS with atezolizumab, and there were expected adverse effects of immunotherapy in this study. This could not become a standard recommendation because it failed to show a benefit. Then we have the Checkmate 914 trial, in which they tried the third immunotherapy drug, that is nivolumab. So this trial included NIVO versus placebo and also NIVO EP versus placebo. Again, clear or sarcomatoid RCC and with the high risk group, that is T2 with high grade and T3 onwards not positive. So the primary endpoint of DFS was not met with NIVO therapy, neither it was met with NIVO plus EP combination. But there was one subgroup which was grade 4 plus sarcomatoid features. There was some benefit we saw with NIVO EP. This is a brief summary of all the trials, the Emotion, Checkmate, Prosper, and Keynote. And we saw that only the Keynote 564 is the only one which showed a benefit. Rest of them did not show any benefit. When we look at the comparison of all these trials, we see the different type of population included. Why did Key 564 have a benefit? So one thing is that the Keynote 564, they studied the PDL1 on the sample more than the CPS. 77% had more than 1% CPS, whereas the other trials did not do this. This could be one of the reasons. And then the Emotion also studied the CPS, in which 60% had a positive PDL1. But in Emotion, we see that the percentage of stage T3, T4, and node positive are significantly less compared to Keynote 564. So these two factors could be the reason why one trial showed a benefit and the others didn't. The other possibility is that the Keynote also included some 6% of M1 disease and a significant percentage of sarcomatoid histology, which we know is associated with poor prognosis and a response to immunotherapy. This could be the other reason. But the absolute clear-cut reason why one trial showed benefit is and the others didn't, we still cannot say with certainty. Another trial, the Rampart study is we are awaiting the results. And in the Rampart study, they have multiple arms. One is monitoring, second is durvalumab, and third is durvalumab plus tremelimumab. And the arm D is going to be added later on. So we are awaiting the results of this trial. There is also some data on neoadjuvant therapy, immunotherapy, durvalumab, tremelimumab, neoadjuvant TKI also. So far, none of this has showed any clinical benefit to become a standard recommendation. So when we compare this PROSPER trial with the other immunotherapy trials, most of the trials did not enroll the non-clear cell histology. And the proportion of patients who were very high risk was more in those trials. Emotion and checkmate did not show an improvement. In survival, keynote did. So in this trial, what the authors did is they investigated whether the population eligible for keynote 564 in the PROSPER trial could explain the survival difference, but this analysis also did not explain. What were the strengths of this study? So it was the first non-placebo controlled phase 3 trial of neoadjuvant plus adjuvant immunotherapy in RCC, which included 60% T3, T4, and around 70% were clear cell, but this trial also included the other histologies like papillary, chromophobe, and mixed. Only 10% in both arms did not undergo surgery, so the 90% compliance with surgery was there. And because there was single neoadjuvant dose, there was no delay in surgery, only 21 days median time. It was a patient advocate guided design, and it showed that doing a biopsy before the treatment was feasible. And we know that 22% in the NIVO arm experienced side effects needing to discontinue the drug. It shows that it does have significant toxicities. What are the limitations? So this trial did not compare neoadjuvant versus adjuvant immunotherapy. Almost 90% were white. It was studying a predominantly Western population. Only 15% were clinical node positive. 40 to 47% were PANX stage. And only 53% of patients could receive the entire course of immunotherapy, which is lesser compared to the other trials. It was 61% with pembrolizumab and 65% with atezolizumab. And we know that perioperative therapy is challenging in the renal cell carcinoma because because of that, we will have decreased enrollment of larger and more advanced tumors. And maybe the open label study affected the actions of the doctors, surgeon, and patients. Since it was not a blinded study, this could be one potential disadvantage. And another important thing to note is that there was only one neoadjuvant dose of PDA of the immunotherapy, whereas these other trials used longer courses of immunotherapy before surgery, like almost 12 weeks. So in melanoma, pembrolizumab, colorectal cancer, dostarlimab, and in NSCLC we have multiple drugs. So all of them showed a survival benefit because they were able to give a longer duration of preoperative immunotherapy. And in most of these studies, the median time to response of immunotherapy was at least 2.5 to 3 months. So a single neoadjuvant dose of nivolumab in this PROSPER study, probably it was not good enough in the preoperative setting to cause a downstaging and reduce the size of the tumor. And lastly, the CT and MRI findings do not always correlate with the pathological staging. So they had to enroll some T2 patients, which are at lower risk of recurrence. So the overall risk of the population becomes less. And enrollment of non-clear cell histology was also allowed. This also could have maybe contributed and confounded the results of the study. These are the limitations. So thank you.
Yeah, so nice detailed summary of all the trials that are there in the adjuvant setting, that is adjuvant TKI and adjuvant immunotherapy. So actually, before we take comments from Kumar sir and Amit sir, so since you've presented a detailed discussion, so what do you think are the take-home messages, or what have you learned? And why do you think there are differences in the various immunotherapy trials? Arvind, I think you can take this question.
Yes. So the take-home message, the first thing we need to realize is these intermediate and high risk RCCs have a high risk of recurrence. So there is an unmet need for adjuvant therapy. They do need some adjuvant therapy. What they need, we are still not sure. TKI definitely is not recommended because it hasn't shown benefit and there are a lot of side effects. In terms of immunotherapy, there are conflicting results. And sir, one potential reason could be, as I had shown in the table, that there was some differences in the trial population. So Keynote had certain high risk population, very large number of T3, T4 and node positive patients. And they had a high number of sarcomatoid histology. They had around 5-6% of M1 disease. And they also had mostly patients who were PD-L1 positive. So this could be one potential explanation. And we saw in Prosper trial, they had to include some T2 patients who are inherently at lower risk of recurrence. But sir, ultimately, what is the real reason? We cannot say with guarantee it is 100% because of this. So I think maybe, sir, some more research will be needed into this area before we can comment. And sir, especially research in terms of longer preoperative immunotherapy, because only they gave one dose. I don't know how much importance we can give to that.
So one clinical scenario before I go to Amit sir. So if there is a 3 centimeter kidney lesion and a 1 centimeter lung nodule, and it has been resected, and it's come as low grades, means it's come as a ISUP intermediate grade RCC, then would immunotherapy be recommended or TKI?
A single lung met and renal lesion. Ideally, if
Yeah,
both are
3 centimeters and 1 centimeter. Small lesions, but there is one single lung nodule and a 3 centimeter kidney lesion. So is immunotherapy recommended in such a situation?
So we will resect both if both are resectable, first of all, and then we can give adjuvant pembrolizumab based on the keynote 564 study, because I mean it is a NCCN category 1 recommendation. So I mean,
So
if
what
the
I'm just
patient,
basically trying to highlight is the M1 NED subgroup. So the M1 NED subgroup was the one subgroup which had the lowest hazard ratios, means the maximum benefit. Okay, so in a case where it is M1 NED, that means a metastatic disease which is resectable. And even if you see in this case, oligometastatic disease with maximum 3 lesions were included, provided three months after surgery, they had no metastatic disease. So basically like an M1 NED. So this is the subgroup which has benefited the most from adjuvant immunotherapy. Amit sir, just one question. It's 1 year of immunotherapy, even from the lung trials and even from here, almost 50 to 60% patients only are able to complete. Sir, any thoughts on immunotherapy? That is one. Secondly, I could not find in this entire study the impact of the single dose of immunotherapy on the resected specimen. Was there more tumor infiltrating lymphocytes or any change in the microenvironment? So, your thoughts on this, sir? Amit sir?
So I think why they choose one cycle is really strange. So this could have been a positive trial if like a lung, if they have chosen 3 month or few cycles so giving only one cycle, I think that may be the one reason. If they could the study design may have led to the negative trial of this study. So I think that is one thing. The other thing which was discussed by they have not taken the only clear cell. So we all know that the other non-clear variant do not have that much response as compared to the clear cell. So that is, there are these seems to be two reasons for that. And the other thing is that M1 NED, they have in this study, I think 3 months after the surgery, whereas in checkmate 564 is the 1 year. And what you are saying that the hazard ratio is close to 0.28 in the subset of M1 NED. So I think nobody knows the reason why the pembro is positive and therefore the critics of this study quote this reason that one is positive and why the 6 trial. So there is a strong rebuttal regarding the real benefit, because rest all trials are negative and only one trial is positive, and that is one reason which is against this study. But that is the science. The data is there, the drug is there, the approval is there. So definitely. So the only question comes for deciding the adjuvant. So in practice, what we do that all T4 tumor, all grade 3, all N plus tumor, and all sarcomatoid tumor. That is where we strongly consider. The only question is T3 grade 3. So should we consider? So that is the real crux in a T3 grade 3 tumor. How much the benefit of a pembro? That is one of the discussion which otherwise in a day-to-day setting you have to offer in a clear cell RCC any tumor which is more than T3 or T2 with grade 4 or T2 with sarcomatide. So I think the study design may have impacted this study. So if they have taken only clear cell, they have taken the higher grades and some more cycle of perioperative, could have been a positive study. But I feel then the point which you mentioned about the tolerance, so that we have to be very careful that it's an adjuvant setting. 20% patient will develop the immune-related toxicity requiring the steroid in their view. So these patients, and these are practically curable patients. So we have to be very little bit careful, and the counseling, the part, the toxicity part needs to be told to the patient and their family so that they can come early and we can intervene rather than waiting for the toxicity to go there. So it's a good drug, but definitely comes with its own bag of side effects, and we have to be a little bit careful.
Correct, sir. So we'll just briefly touch upon the prognostic or the predictive markers. So PDL1 has been highly discussed, and there is like conflicting or variable data. I think Randir, first I can ask you this question since you've reviewed this literature. Any role of PDL1 as a predictive factor to say that immunotherapy is going to work well, not work well? And apart from PDL1, do you think there are any other prognostic markers?
PDL1, there is a role in metastatic setting, sir, but there is no role in this setting of patient. So irrespective of PDL1, immunotherapy can
even in metastatic setting, is there any you suppose if even in metastatic setting PDL1 is negative, you will not offer immuno to that patient?
Immunotherapy will be offered irrespective of PDL1 also, sir.
Yeah, so at such, that is the only tumor where at least the among all tumor the pembro approval is based on the not based on the PDL1. So all in the urothelial and the kidney tumor, you can give pembrolizumab to in a metastatic setting to all patients irrespective of the PDL1.
Yes, sir, irrespective of PDL1. So there is no role for PDL1.
So I agree completely to what Amit sir is saying. So there have been conflicting results. Even in the metastatic studies, some of them have predicted, whereas in some of the studies, PDL1 has not been predictive. In fact, in certain studies, PDL1 has been a prognostic marker for inferior survival. So in an RCC, the role of PDL1 cannot be completely relied on. That is one thing that I'm saying. Secondly, when you spoke about the keynote 564, this was one study where PDL1 more than one showed a benefit, but it could not be translated or reflected in a number of other studies. That's what we want to convey. Secondly, any other markers other than PDL1? Like, do you think there is any role for MSI or TMB or anything else?
If it other prognostic markers, if mainly the tumor stage, nodal status of the disease and metastatic disease, time to metastasis. If these are all the various prognostic markers, including various laboratory parameters, which prognostic schemas were used, sir, for prognostication. For example, IMDC model, which included various lab parameters to assess the prognosis in the patients.
Correct. So these are there. Sir. So we were just basically discussing, are there any other genomic signatures? Like you must have read about the neoadjuvant chemoimmunotherapy trials in lung. Or in other situations where they've assessed MSI, ctDNA values, TMB. So all of these are the other prognostic markers, but have they been developed in RCC? That's the question. So Amit sir, any role of any marker other than PDL1?
No data.
I don't remember that anything. The only way in a palliative setting, the EP-NIVO study, there is some benefit in terms of patients who expresses PDL1. Otherwise, we don't know the marker for immune. That is, I think, because if we have to select the markers, I feel that MSI is the best marker to decide. TMB is the weakest among all that. PDL1 is plus minus. So I personally feel that the tumor mutation burden, and we have tried many times, more than 10, we tried to give at least in the blood, it has to be taken with the full spoon of salt rather not the pinch. So TMB is the worst of all marker. MSI is the best. PDL1 is between all across. But for RCC, I don't think so that there is any such marker. The people tried in a metastatic setting. If you someone wants to read about the detail, the Bionic study. It's a French group study which they tried to define the various gene signature, and they divided into 4 groups: CRCC 1, 2, 3, 4, depending upon various gene expression, which they have not mentioned was gene, but they have divided into that group. And then they did a randomized study selecting the immunotherapy or TKI or combination as per the CRCC 1, 2, 3, 4. So that trial showed that it was a phase 2 study. Since it was an institutional study, it was not much discussed, but it's worth to read that study, the Bionic 2. In that study, they found that if you select the patient for a palliative setting therapy as per the gene signature, the survival was same. So in a palliative setting, there is some data that selecting the TKI or immuno or a combination as per the gene signature, there is some emerging data. But for adjuvant setting, till now, I don't think so that there is any validated test. But it may come at some point, but at this point of time, no.
Correct. So actually, we were just going to go to the role of NGS and genomic profiling in RCC, and is there any role? I think Megha has done some reading. So Megha, do you think there is any role of NGS in RCC, and could any of these genomic profilings decide on what we plan for the patient? Like if we have to plan TKI, or if we have to plan immunotherapy. So does any of these genomic profiling markers or signatures help?
Hello. Am I audible, sir?
Now you're audible, yeah.
So NGS has a role in metastatic setting. It has been, there was a phase 3 trial in which was done, sir, which showed that in the NGS targeted therapy in metastatic setting in RCC, there was a benefit in PFS, sir. NGS targeted, we can give sunitinib, sir. In the study, it was compared between sunitinib versus everolimus, sir. And the study did not meet its criteria in the everolimus SAM. It was stopped, sir, because it did not meet the PFS goal. But in metastatic settings, sir, it has been shown to have some benefits, sir, mainly in the VEGF receptors, sir.
Okay, so what are the commonly found, means altered or mutated pathways in RCC, and the commonly mutated genes that you have frequently read about or you must have seen in RCC? I think I think others can also help. Randhir, Sagar, Arvind, commonly mutated pathways or genes in RCC that you may encounter?
VHL gene status, RCC, sir.
Pardon me, come again.
VHL gene status.
VHL. Okay. Any other?
Carbonic anhydrase 9.
Correct, that's one of the receptors. Any other commonly mutated genes that must be or maybe therapeutically targetable? Anything else?
We have the fumarate hydratase.
In the clear, non-clear also, non-clear. So you are saying, is there anything in the non-clear group which can be targetable also?
Actually, what sir is saying is correct. So initially, all the NGS was done. Initially, all the NGS was done for non-clear RCCs because they thought that they were more genomically driven as compared to the clear cell. Okay, so the number of targetable gene alterations are in fact found more in non-clear as compared to clear. Now you can tell what Amit sir is asking, that are there any genomic markers that are targetable in non-clear RCC?
So ERBB.
Which pathway? ERBB2. So not
Yes.
in this cancer, but in other, not that much in RCC. In which other urological malignancy, the ERP-P2 is now the hot topic of discussion. Which tumor? In which urogenital tumor? Not in RCC. Bladder tumor. Yeah, so now gradually the HER2 expressing the bladder tumor is going to be a separate entity. The people are trying for newer and newer drugs. In RCC, I think the mTOR pathway is that is one of the easiest triggable, and what you told, the MET. So these are the two pathways which can be targeted easily if we find that. I think there was one randomized study of a MET-directed therapy in non-papillary, the savolitinib. Yeah, so I think the work is already ongoing on this these pathway for identifying or defining the treatment options as per the marker. So mTOR and the MET pathway can be one of the and rarely we can find the ALK. Rarely, so we have tried only in one patient, but not good result. But theoretically, the ALK. So now the ALK mutated RCC is one of the rare entities that has been in the literature.
Correct. So in fact, Megha, the study that you were saying of sunitinib versus everolimus is primarily for the PI3K mTOR pathway, followed by the VEGF pathway. Sunitinib is primarily for the VEGF pathway, followed by the others. So in fact, the study that you were saying one versus the other was primarily PIK3. Other commonly seen is BAP1. So that is BRCA-associated protein 1. We see ALK translocations. We see few of these SETD2 and ARID1A. All of these are like other molecular or genomic markers that we see. So it is an evolving field. Roughly around 15% to 18% of non-clear cell RCC show therapeutically targetable gene alterations. Okay, as compared to clear cell. So clear cell, there is VHL. So VHL is one of the other genes that we are targeting. And what is the drug for VHL?
Belzutifan can be used.
Correct. Belzutifan. I think that's enough. Amit sir, any other comments or thoughts on this?
Amit so I think the only thing is the takeaway message is that this field of adjuvant treatment is still evolving. The only approved drug is pembrolizumab, and the patient population which we have to select for adjuvant pembrolizumab is the all T4 and N+, T3 with grade 4 or sarcomatite, T2 with grade 4 or sarcomatite. Only clear cell RCC, no data till this point for the non-clear RCC. The M1 NED patient benefited most. The M1 NED means that you have done a primary surgery and a metastectomy of the lesion within 1 year. Sarcomatite benefited most. So these are the two patient population where definitely we have to discuss for the benefit of adjuvant and node positive and probably T4 also. So these are the patient population, and the toxicity of the pembrolizumab in adjuvant is close to around 20%, grade 3, grade 4, requirement of steroid and close monitoring of these patients, because these are the cured patients practically. So you don't want the patient to land up in the complication because of the immunotherapy. So a detailed discussion regarding all possible signs, symptoms of the immune-related toxicity has to be explained to the patient and family, and close monitoring is very much required.
Correct, sir. Correct. Mishra sir, any final comments or thoughts, sir? Kumar sir is not there. Mishra sir, if you're there.
I think it is a nice discussion, and Dr. Ambiju rightly highlighted that we have only one approval, but again we need to explore the duration of adjuvant therapy. New adjuvant timing, it may give some insights. So I think we need to keep searching on the options of the adjuvant therapy in these RCC.
No, absolutely correct. So probably if you can shift some of the immunotherapy or make it into perioperative, probably we can have some predictive responses in the specimen, like how we have in neoadjuvant lung or neoadjuvant other trials. So probably we can shift some of them in the neoadjuvant NC and alter the duration in the adjuvant. That's a really valid point, sir. I think if there's no other, Amit sir, then closer class if there is no other comment.
Yes.
Okay. Thank you, everyone. Thank you.
Thank you. Thank you.